want to thank Dr. Hazy and Dr. Peatland for inviting me, as well as the SAGEN's program committee, to participate in this panel. What I'm been asked to talk about is what's the best algorithm for you. And the problem is I don't know all of you, and you don't know me, but what's best for me and what's best for Dr. Hazy or Dr. Peatland is very different. And so in terms of, first off, my disclosures, these are industries that have nothing to do with management of common bile duct stones, but I do have to disclose that I love to do ERCPs. Part of my training is in GI endoscopy, so I do come with bias, as we all do when we come to manage stones, but I will try to exclude that when I talk today. So what is the best outcome in reference to? When I was asked to give this talk, you always want to take a step back and say, well, what are they looking at? I'm going to reiterate a little bit of what you've heard in the 5 previous talks about the management of stones. There's not a lot that we can do in terms of new ideas, but the question is it best for the patient, best for you, best for the institution, or best for society? And I think we have to look at all of these and figure this out. So I think we all would agree, as physicians, we want what's best for the patient, at least up at the forefront, the least morbidity, least mortality, maybe the least numbers of procedures, possibly, the least amount of pain, and maybe the easiest recovery. And I think we all would agree, therefore, that maybe, as Dr. Andres had said, a laparoscopic approach might be best. What about for the surgeon? I mean, you got to go home and come back the next day. And unfortunately, I think we all have to be honest with ourselves, but we want to do something that's easy, maybe quick, the least amount of complexity for ourselves, and the greatest patient satisfaction. And I think we all have to take those points into consideration when we do a procedure. What about for the institution? Well, I think we all are under the microscope when it comes to things that we do for our institution in terms of hospital stays, expense, as well as the least amount of resources utilized. Dr. Anders referred to things that are on the shelf, and if it's only used once or twice a year, it's kind of hard to find those tools on the shelf. And again, patient satisfaction, one of the factors that will be looked back for our 360 evaluations, and patient satisfaction is very important, possibly down the road in terms of our monetary reimbursements. What about society? Again, looking at this globally, we want things that are least expensive, quickest return to work to get our patients back into the workforce, and maybe the minimal use of resources that can come into factor. And so when we look at the best algorithm, and again, I don't have the answer for you. There is, unfortunately, no one answer for everybody, but we have to look at the factors of the patient that's individualized on the table that day. Ourselves, we have to really look at ourselves, and Clint Eastwood said, you know, a good man or woman knows their limitations. You have to know what you bring to the table and what you're able to do, and what our hospital actually supplies for us in terms of the actual physical resources, as well as the other doctors that work at our hospital. So when I look at the patient factors, when it comes to finding the best algorithm, and you've already heard this through a couple of the other talks already, if someone's had a gastric bypass, that makes things much more complex when it comes to an endoscopic approach. People with underlying comorbidities, maybe they can't undergo a 3 or 4 hour operation, as well as their anatomy. If the bile duct is only 4 millimeters in diameter, probably the only place that you're going to want to cut it is at the bottom, at the papilla, and you're probably not going to want to do a choledochotomy if you can't manage things transcystically. What about the physician factors? And I think this is the most important slide I want you to take home from my talk today, is that you need to know what you bring to the table, as I said. What is your skill set in open as well as laparoscopic common bile duct expiration? And again, it's very hard. We all come from different generations of training, and I think that it's very difficult for our residents to come out today. Dr. Anders presented some data from our institution, but it is important to understand not only your skill set, and again, this is an important slide, but what is the skill set if you aren't the person doing the ERCP? If your GI cohort at your institution maybe doesn't do a lot of ERCPs and they're not very skilled at it, and it's going to come back to you when they're unsuccessful in a post-operative ERCP, now you're looking at a third procedure, all right? So remember that when it comes to creation of your algorithm, well, what is there? Are they getting 60% of the stones, or are they getting 95% of the stones out? And also your time availability. In terms of resources on the shelf, as Dr. Anders alluded to, you have to have laparoscopic as well as open tools to manage these in a surgical fashion, but you need an endoscopically trained physician if you're going to approach these with an ERCP. ERCP is not something that is easily tackled. It takes years and years of training and skill sets to improve our ability to get obviously a good management of common duct stones, and you need those endoscopic tools. So can you do an ERCP in the OR? It can be done, but you're taking a patient procedure that normally is done in a prone position, putting them now supine, limiting the endoscopic physician's ability, because all their tools maybe aren't in the OR, and having to move a GI cart to the operating room. So again, it does increase the complexity for your endoscopic management of stones. So we've seen some pros and cons already, and I'm going to give you mine in terms of what I want you to take home. And again, look at yourself, look at your institution, think about the people you work with at home. So what are the pros of doing an ERCP? Well, again, it's done under moderate sedation, although many days we are doing these under general anesthesia. There is very minimal recovery to it. There are very rarely external tubes with this unless you're doing a rendezvous procedure with a PTC catheter, and the success rates are pretty good. It's about 85 to 95%. What are the cons of any, and this again is for preoperative and postoperative ERCP, not in the operating room, but just an additive procedure, all right? It's a second anesthetic, and again, that does add cost, maybe patient satisfaction issues. There is inherent morbidity and mortality every time we do an ERCP, and what I try to train my residents is ERCP is not a diagnostic procedure. It has a 1% mortality, about a 0.5% risk of bleeding as well as perforation, and it is a very risky procedure if not done with appropriate indications. And the other thing is, again, this is probably a little bit more esoteric, but the idea of a sphincterotomy in a younger patient, there have been some anecdotal concerns of cholangioduodenal reflux in terms of risk for cholangiocarcinoma. So what do we know about ERCP in terms of what success do we have with that? And it's pretty good, all right? In meta-analysis, okay, comparing ERCP to MRCP, MRCP is good for sensitivity. ERCP, on the other hand, is associated with false negative a little bit, all right? Every time we inject contrast, whether it be an intraoperative cholangiogram or an ERCP, there's a definite risk of missing common duct stones. The other thing is, if it's unsuccessful, if we do an ERCP and I can't get those stones out, I'm going to have to come back and either do another ERCP or approach this patient with another type of intervention. So let's look at common bile duct expiration, and any one you bring to the table, whether it be a laparoscopic, an open, or even an intraoperative ERCP. So all comers for intraoperative common bile duct management, what are the pros? Single operation, single sedation, that's a great algorithm. If I can take care of things all at once, but again, you gotta have the right patient and the right skill set. It's highly effective, we know it's cost efficient, as Dr. Hazy alluded to, and there is a rare need for a second operation. What are the cons? Well, again, if it's not an ERCP and it's actually an open or a laparoscopic common bile duct exploration, you're most likely going to leave a T-tube in, all right? In a duct that's pretty small, the risk of stricturing is quite high after choledochotomy, and although there have been numerous series, Dr. Franklin, many others, Dr. Peatland have done choledochotomy, if you are not skilled to do laparoscopic sewing, and be honest with yourselves, this is a small system. If you can't do a good closure, you're going to have an issue without leaving a T-tube. The other thing is there is some issues in terms of training, and we're going to always come back to that. At the end, I'm going to kind of touch upon that, but it requires additional equipment. As soon as you're in the operating room and you say to your nurses, go get me a choledocoscope, go get me the T-tubes, go get me, God forbid you want some Baker's forceps or some of the things from our past for open common duct expiration, they're just gonna put their hands up in the air. They're gonna have no idea. And so that algorithm doesn't work very well, and that's not a very efficient use of our operating room. So what do we know about common bile duct expiration? Well, I think as you saw in the other talks already, with the improvement in our laparoscopic skills from 25 years ago, all right, the equipment has improved, our skill set has improved. Unfortunately, the number of cases we're doing hasn't improved, all right? So I think we're better surgeons. We're just not doing this operation. There's a very good stone clearance with any of these approaches, probably approaching almost 90 to 95%, small morbidity, and obviously a very small mortality. So I know the data you saw already was in favor of several of the surgical procedures, but here's a meta-analysis of all these randomized controlled trials that were put together, and there really is equivalent stone clearance, whether it's going to be a two-step or a one-step procedure. The other thing, at least in this meta-analysis, all the other factors were similar as well in terms of mortality, length of hospital stay, total operative time, as well as hospitalization charges. And I think what this study showed was that when they only pulled 7 randomized controlled trials out of about 50, and there was almost 800 patients, is they found trials that were basically a little bit more recent, where people can get an ERCP and go home, all right? You don't need to keep someone after an ERCP, and I think that that's why this study shows a little bit better algorithm for that procedure. So here we go. So what are the algorithms that you can take home with you? And again, You got to fit the right patient into the right algorithm. There is no one way to do anything. You can't fit the square peg in the round hole. You can do just a pre-op ERCP alone. We could do an ERCP followed by any type of cholecystectomy. We could do a lap chole, all right, plus a duct exploration, or then we can also do something open, as well as a chole with or without pre-op or post-op ERCP. So in the algorithm, who gets a pre-op ERCP alone? Again, if there's an indication, as you heard in some of the other talks, whether it be persistent jaundice, cholangitis, persistent pancreatitis with possible obstruction, these people probably need clearance of their duct. And if they cannot undergo a surgical intervention afterwards, you're going to just do the preoperative ERCP alone. When you look at studies of ERCP and sphincterotomy without subsequent cholecystectomy, the risk of stone disease in the gallbladder causing a problem is probably less than 15%. All right, so in those patients that you don't feel are a good candidate, just leave it alone. The next thing is ERCP followed by cholecystectomy. Again, the same indications for your pre-op ERCP, but now you're going to go ahead and take them on to do the cholecystectomy. And in the case of having limited resources, where you are not skilled, you don't have the equipment, or you don't have the endoscopist, getting those stones cleared pre-op is the algorithm for you, all right, or for that situation. What about intraoperative management, all right, whether it be by common bile duct exploration or intraoperative ERCP? Again, you need to have the resources to be able to do this, and it's probably not going to be in the patient that has that requirement for the preoperative clearance of their duct. Finally, lap chole, okay, plus a post-op ERCP, not management of stones in the operating room. Again, know your limitations. Either some morbidity of the patient or anatomy limiting your intraoperative ability to do a common duct exploration. They have a very small duct, it's very inflamed, or you don't have the skill set or the resources to perform the common bile duct exploration, so your algorithm is going to proceed to a post-operative ERCP. So finally, you saw this already posted. This is George's paper that just came out last month that's looking at the concept of management of common bile duct stones. And I think it's a very important thing to understand is surgeons and GI physicians, we need to learn how to manage this in an algorithm that seems most appropriate and opportunistic for our skill set. And as the chair for next year's 2014 annual meeting, you'll be happy to know that one of the things that we're looking to do as a hands-on course and a postgraduate course is revisiting common bile duct exploration. So hopefully we'll see all of you next year for that. Thank you very much.